Okay, great.
Good morning, everybody. Welcome to Grand Rounds. Today we have a wonderful speaker, Dr. Tal Weinberger. She serves as an outpatient medical director for the Department of Psychiatry, and she has a second faculty appointment at the Department of OBGYN at Thomas Jefferson University. Dr. Weinberger completed medical school at University of Pennsylvania. She completed psychiatric residency at the Hospital of University of Pennsylvania and fellowship in cognitive behavioral therapy at the Center of Cognitive Therapy in the Department of Psychiatry at University of Pennsylvania. She's the founding director of the Jefferson Women's Mental Health Psychopharmacology Specialty Services, which is a specialized clinic providing supervision, teaching, and clinical care in women's mental health. Welcome, Dr. Weinberger.
Thank you so very much for that lovely introduction. I'm so privileged to be here today. Thank you so much for inviting me. I am just going to share my screen. Okay. All right, can everybody see that?
Yes.
Okay, awesome. All right, so today we're going to talk about bipolar disorder during pregnancy and lactation. Okay, so I just want to start by talking about sort of some basic definitions, because I think often there's some confusion and misunderstanding about what bipolar disorder actually means. Bipolar disorder is a condition that is both commonly underdiagnosed, and I tend to see that more on the outpatient end of things, and overdiagnosed, which I think we see more on the inpatient end of things. And so there's often a lot of sort of confusion around the diagnosis. And I think a common narrative that we both see on the inpatient end is that a patient, comes to your service with a diagnosis of bipolar disorder and, tells you they have a diagnosis of bipolar disorder, and you consult us and we come and see the patient and we say, no, actually, it's not bipolar disorder. So just to sort of, kind of lay the groundwork in terms of what we're talking about, when we're talking about bipolar disorder, we're talking about sustained episodes of depression, alternating with sustained episodes of elevated mood or irritability, which is classified as either mania or hypomania. Hypomania means basically an attenuated form of mania without really significant functional impairment. So the patient who's, kind of classically, kind of running naked on the highway is manic, as opposed to somebody who might just, be sleeping 4 hours a night and planning a party for 200 people, like that sort of thing, which is, kind of outside of their normal range of functioning, we would call more hypomanic. When we talk about mania, we're talking about, again, like a syndrome. It's a spectrum of symptoms, including a combination of increased energy, decreased need for sleep, meaning the person is not really, sleeping as much as they normally do. They're sleeping less than usual, but they still retain, either normal or excessive energy. Their speech is often rapid and difficult to interrupt. They describe their thoughts as racing. They can be very distractible, jumping from one topic to another. They can be very impulsive and labile, and grandiosity, meaning that they kind of believe generally that they're sort of, their capabilities extend beyond what their normal expectations would be, which again can range from, I'm going to write the next American novel to, I'm gonna, kind of pursue this relationship that's, maybe unrealistic. Again, this is, we're talking about a sustained, so, by definition in the DSM for hypomania, we need at least 4 days of continuous symptoms. for hypomania. And, but in general, kind of what we want to see is that the symptoms are sustained, that they're not kind of coming and going over the course of a day. So I think where we kind of get the most misunderstanding is where when we see patients with mood swings, and we frequently see patients with mood swings. I think, we do and you do. Patients with a lot of, lability in their mood and a lot of, difficulty regulating their emotions, and especially in the context of perhaps chaotic, life circumstances and relationships. And mood swings are really not adequate for a diagnosis of bipolar disorder. We see mood swings as a part of a lot of other syndromes, including personality pathology and other things as well. But again, what we want to be seeing to make a diagnosis of bipolar disorder is a syndrome characterized by sustained symptoms lasting for several days to weeks. Okay. So more definitions, and this is just, I think, going to be important for the purpose of our discussion. We talk about two different forms of bipolar disorder. So there's bipolar disorder type 1 and bipolar disorder type 2. Both of them can and often are characterized by quite severe depressive symptoms during the depressive episodes. And in fact, both are really predominated by depressive symptoms. So often women or people in general with bipolar disorder will spend most of their course of their illness depressed, and really just, a small percentage of it manic or hypomanic. And so, again, that's sort of an important thing to keep in mind when screening, is that really may be kind of what the patient is focusing on, because number one, that's the thing that's sort of causing the most distress and impairment. And number two, it's really, the depressive phase is really the predominant phase of the illness for them in terms of, kind of what they're experiencing in their life. So bipolar disorder type 1 and type 2 are really distinguished not by the severity of the depression, but by the severity of the mania. Bipolar 1 is a more severe form of bipolar disorder defined by at least one sustained manic or mixed episode. And so when we say, again, manic, we mean, really kind of severe symptoms that cause significant functional impairment. And when we use the term mixed, that's a little bit of a confusing term, but generally what we do mean by mixed is episodes that are really characterized by simultaneous manic and depressive symptoms. When we say bipolar disorder type 2, that is, again, really often really predominated by depression, but characterized by sustained episodes of hypomania. So again, manic symptoms that are much more subtle and more likely to be missed and less severe and cause, less functional impairment. Okay, so now we're through with our definitions. Let's talk about gender. So our lifetime prevalence estimates for bipolar 1, again, the more severe form of bipolar disorder characterized by a more severe form of mania, about 1% in the population. And we see men and women affected at equal rates. There's no kind of gender distinction. Bipolar 2 is pretty similar. We see lifetime prevalence estimates about 1.1%, but interestingly, in bipolar 2, we actually see a ratio of women to men of about 2 to 1. So, which is interesting, right? Because that's the same ratio that we really see pretty consistently across, culture and socioeconomic status in unipolar depression, right? Like we see a pretty consistent 2 to 1 ratio of women to men. And in bipolar 2, we really see a similar ratio. In general, women with bipolar disorder tend to spend more time than men in the depressive phase of the illness. So people of both genders tend to spend more time in the depressive phase of the illness, but even more so women relative to men. And we tend to see an average age of onset in the late teens to early 20s, which is really kind of a setup to put affected women really at pretty high risk during their reproductive years specifically. Okay, so thinking about pregnancy, and this is a complicated issue, and it, legitimately so for women with bipolar disorder. And this is older data, and I haven't seen anything more recent, but it's interesting. I wonder what this would look like if we looked at it. We looked at it more currently, but about 20 years ago, 45% of women with bipolar disorder reported that they'd been advised to avoid pregnancy altogether by a healthcare professional. So like almost half. got that advice just as a function of their bipolar diagnosis. Many had also been advised against pregnancy by a family member. And in fact, in this study, over a third actually decided to avoid pregnancy, as a function of that advice or other factors. And most frequently stated reasons were, again, legitimate concerns, fear of adverse effects of medication on fetal development, which is absolutely a legitimate concern, and also fear of relapse if treatment is discontinued, which is 100% a legitimate concern. However, we do see unplanned pregnancy and voluntary termination of pregnancy more frequently occurring in bipolar disorder. And so for many, many, many reasons, this is sort of an important issue for us to think about and tackle. Okay, so thinking first about impact of bipolar disorder on the course of pregnancy. And this is something I really kind of emphasize a lot when I talk to audiences of psychiatrists that I think, maybe needs to be emphasized a little bit less with this audience, but the impact of untreated illness is not benign. And anytime we think about impact of treatment on pregnancy and postpartum, we're going to be talking, a lot more about postpartum because that's really sort of where the meat of the issue is. But anytime we think about the impact of treatment, it's really hard to separate that out from the impact of illness, right? Because just by definition, anytime we're studying the effects of treatment, we're also studying the effects of illness, because we're not, randomizing healthy women to treatment for bipolar disorder. And so a lot of the studies that we have are really sort of confounded by that, by indication. And studies that attempt to sort of separate out effects of illness from effects of treatment are imperfect and also much less prevalent. But this is one of them. And so this is a study that looks at pregnancy outcomes comparing women with bipolar disorder who are treated and women with bipolar disorder who have opted out of treatment, and comparing those two groups to women without bipolar disorder. Again, caveat, right? These are not randomized, right? They're not randomized to these groups, obviously. So women with bipolar disorder who have opted out of treatment, on the whole, are likely to be a group of women who are less severely ill. And so we're not really comparing apples to apples, but this is kind of the best we can do. So what we see is that actually untreated bipolar disorder in this study was associated with a number of adverse outcomes, adverse pregnancy outcomes, increased risk of infants being small for gestational age with microcephaly and with hypoglycemia. And we actually see increased risk of preterm birth in both treated and untreated women. So again, right, sort of underscoring the fact that untreated illness is really not benign. And we see rates of congenital malformations in this group at about 3.4% in the treated group, which is, it's pretty similar to the population, right? But in this study, so 3.4% in the treated group, 1.9% in the untreated group, and 2% in the group with no diagnosis. So here's another study, kind of with similar structure, comparing women with bipolar disorder who are untreated, women with bipolar disorder who have opted to continue their treatment, and comparing those two groups to unaffected moms. And in this study, we actually saw similar outcomes for all groups, except for one finding of decreased head circumference in the group of women with bipolar disorder who are untreated. Again, imperfect, because the groups aren't necessarily, they're not randomized, and so they're not the same. This may have been a more disadvantaged group from a socioeconomic perspective, and that may account for the difference in head circumference. But it's also possible that we're seeing a protective effect of medications here. Okay, so we're going to talk more briefly about antenatal illness, and then we're going to move on to talk about the postpartum period, which again is highly significant in this illness. And then we're going to focus on treatment. Okay, so antenatal episodes are often depressive, obviously not always, but often. We can often predict that if a woman has an episode in one pregnancy, she is likely to have a recurrent episode in a subsequent pregnancy. So, so we tend to see recurrent episodes in the context of pregnancy. And a little bit less than a quarter of women will experience mood episodes during pregnancy itself. And this is similar for women with bipolar 1 versus bipolar 2. So thinking about continuing versus discontinuing treatment during pregnancy, and this, again, this is sort of older data, but there actually has been more recent data supporting this, that we see that women who stop their maintenance mood stabilizers tend to relapse much more quickly and are at much higher risk of relapse during pregnancy than women who continue their maintenance mood stabilizers. And this is sort of not unexpected. Okay. Now, this is a really, really important point. I think I want to kind of underscore this as one of the important take-home points, that recurrence of symptoms during pregnancy really strongly predicts the onset of postpartum episodes. And the reason why this is so important is because often symptoms can kind of creep up and be kind of subtle. A really common clinical scenario that I see is people who are sort of kind of starting to develop subsyndromal symptoms, towards the end of their pregnancy for various reasons. But they're not, they're not super concerned about it. They don't feel like they're impaired yet. But a really important point in counseling is that really, the best thing that we can do to try to protect a woman's stability in the postpartum period is keeping them rock solid stable during pregnancy. The postpartum period is just such a vulnerable period. And if a woman kind of goes into it already kind of a little bit unstable, it's really kind of a setup for, for that to kind of, snowball. And so, I really sort of emphasize this when I'm counseling my patients, that even if a woman is experiencing symptoms that she's not super concerned about and she's experiencing as tolerable, especially during pregnancy and towards the end of pregnancy, that's something we really want to be very, very, very vigilant about, because that's, kind of one of the most important things we can do to try to protect her from a postpartum episode. And in fact, about half of postpartum symptoms start during pregnancy. So, again, sort of these sort of subtle, decline, what we call roughening, towards during pregnancy and towards the end of pregnancy, that kind of, ultimately, where women ultimately wind up decompensating, more catastrophically in the postpartum period. Okay, so that's that. I want to move on to postpartum again, because this is really sort of the most important part of the discussion. And we see in general that hormonal fluctuations associated with reproductive life events in general do tend to affect the course of bipolar disorder, that women tend to be vulnerable during times of hormonal fluctuations specifically. We don't see, abnormal hormone levels during these time periods, and women will often ask about that, like, well, clearly, right, like, clearly there's a hormonal trigger, like, do you want to check my hormone levels? Are they abnormal? And the answer is no, that women with bipolar disorder and other mood disorders who experience symptoms during these times of hormonal fluctuations aren't necessarily their hormone levels are going to be the same as women who aren't experiencing these symptoms. But what we think, and what the data seems to be pointing towards, is that these are women who tend to be more vulnerable to hormonal fluctuations. And so we see particularly vulnerable periods occurring during the luteal phase of the menstrual cycle, both in women with bipolar disorder and women with other mood disorders. We see vulnerable periods occurring during perimenopause specifically, and the vulnerability seems to actually go away pretty much entirely in the postmenopausal period, and then in the postpartum period specifically, which is what we're going to focus on. We see really extreme vulnerability to postpartum episodes as a unique feature of bipolar disorder as opposed to other mood or psychotic disorders. We do see obviously vulnerability to postpartum episodes in other disorders, but really sort of this like really super extreme vulnerability is unique to bipolar disorder. This is a kind of dramatic number that I'm gonna kind of bring to underscore this point. Women with bipolar disorder have a 23 times, right, 23-fold greater risk of being admitted to a psychiatric hospital within 30 days after delivery compared to women with bipolar disorder at any other point in their life. Okay, so again, huge increased risk in the postpartum period, especially in the immediate postpartum period. And what we see is specifically in bipolar disorder that we tend to see episodes of mania or psychotic depression in women pretty soon after delivery, generally within the first 4 weeks. Mood episodes that are more depressive without psychotic features can occur in this period, but also, can occur more later in the postpartum period. But we do tend to see mania and psychosis fairly early in the postpartum period. And then speaking about relapse risk in general, overall relapse risk, looking at sort of the population of women with bipolar disorder in general, sort of regardless of treatment or other factors. So the overall relapse risk in the population is about 35%, so a little bit over a third, which is a pretty high number. But then another really, I think, important point is that when we stratify these women and look at them separately in terms of women who have maintained their mood stabilizers versus women who have discontinued their prophylactic mood stabilizers, we actually see a 66% relapse risk in women who discontinue treatment. So like women who stop their treatment are like 2/3 of them are going to relapse in the postpartum period. So it's a huge number, right? We see about 23% relapse risk in women who continue their maintenance mood stabilizer. So I think, kind of two important, I think points to really emphasize from these numbers. These are really important numbers. The points I really want to emphasize are, number one, we can very powerfully affect outcomes here, right? We see that we can decrease relapse risk from 2/3 to like a quarter if we continue treatment. And again, this is a population-based study, right? We don't know that this is optimal treatment. We don't know that these women were treated, to absolute remission. But sort of despite that, we do see like this really like dramatic treatment effect in the postpartum period. But I think that the other really important point to emphasize actually is that if you look at that 23% number, that's like a pretty big number, right? Like that's like a quarter of women are going to relapse regardless of treatment. And again, we don't know that this is optimal treatment, but this is the treatment that people are getting in the community. And a quarter of women are sort of relapsing despite their best attempts and their provider's best attempts at treatment, which again, I think really underscores how vulnerable women are in this period, and how, kind of how vigilant we have to be, in the immediate postpartum period. All right, so thinking about prevention, and we're going to obviously talk more in detail about treatment, but the data that we have really focuses is a lot on lithium, thinking about lithium prophylaxis, and we see lithium prophylaxis is quite effective in the prevention of postpartum episodes. There are also some studies looking at lamotrigine, which is also found to be effective for prophylaxis in one study. Practically speaking, and I'm going to emphasize this point later on, the medication, these mood stabilizers are not interchangeable. And there's really a very, I think, very strong reason to try to work with a medication that has been effective for a woman in the past. And so that's kind of where I would go clinically. If we know that a woman has really had a really good response to a specific medication, that would be the medication I would really try to optimize in the postpartum period, because we know that that's a medication that works for that particular woman. Okay, so postpartum psychosis is another really important topic to talk about. 25 to 50% of women with bipolar disorder will have an episode of postpartum mania or psychosis. Hypomania, so again, really sort of subtle, might be missed, not really like dramatically impairing functioning. Hypomania can be an early symptom of postpartum psychosis, and then that's something that should be monitored very closely. With postpartum psychosis, we tend to see a very, very rapid onset of symptoms, often within like 2 to 3 days of delivery, like really pretty precipitous. And strikingly, about half of the episodes of postpartum psychosis are really the first manifestations of mental illness. So this is, kind of this woman's first ever lifetime episode, and it's occurring in the postpartum period. About half of women will present in that way. Another really sobering number that I think is important to be aware of and to think about, when counseling patients, is infanticide. Postpartum psychosis is associated with infanticide, in the context of, women who are otherwise, devoted and caring moms, really, being incredibly impaired. And we see actually an incidence of infanticide in women with postpartum psychosis, specifically with depressive features. So that's important. But postpartum psychosis with depressive features is estimated to be as high as 4.5%. So that's a huge number. And really, I think, again, sort of like really emphasizes how much of an emergency this is, and how closely we need to really screen for it. So is postpartum psychosis bipolar disorder? This has been a question that's sort of been debated over the years. When I was in training in my residency, we were taught that it was, that postpartum psychosis, if a woman presents with an episode of postpartum psychosis, then by definition, that's her index episode of bipolar disorder. She's going to go on to, declare herself as a patient with bipolar disorder. Interestingly, the DSM-5 does not recognize postpartum psychosis as a distinct clinical entity on its own. That is something that is being, kind of hotly debated and contested right now. But right now, there's no postpartum psychosis diagnosis in the DSM-5. It does happen that women with first episode postpartum psychosis are often given a diagnosis of bipolar disorder. I would imagine, because clinicians are trained, as I was, that's what it is, that postpartum psychosis is bipolar disorder. But there was this interesting study that was done pretty recently that looked at this question, like, does postpartum psychosis necessarily equal bipolar disorder? Do all women with postpartum psychosis go on to develop bipolar disorder? And this was like a really good, well-designed study where women who had one episode of postpartum psychosis were tracked out for a mean follow-up of about 16 years. So they were followed for quite some time after their index episode. And what they were followed for was, would they then go on to develop other episodes, not postpartum episodes outside of the postpartum period, that were consistent with bipolar disorder. And interestingly, more than half did, right? So about 57% did go on to develop recurrent non-postpartum episodes consistent with bipolar disorder. So we see that it's true that postpartum psychosis is really an incredibly powerful indicator of bipolar disorder. However, this is not true of everybody, because about 44% did not. So 44% of women with a first episode postpartum psychosis, followed out for an average of 16 years, went on to have no recurrent episodes, or recurrences isolated to the postpartum period. So they had other episodes of postpartum psychosis, but they had no episodes consistent with bipolar disorder outside the postpartum period. So what this does, I think, teach us is that risk of postpartum psychosis ultimately declaring itself to be the first episode of a chronic bipolar disorder is extremely high. Women with postpartum psychosis, all of our red flags should be up, and we should be kind of monitoring for bipolar disorder going forward, because the risk of kind of going on to develop it is extremely high. But we do see this phenomenon of isolated postpartum psychotic illness, which is a distinct clinical entity requiring further study. So again, sort of not every woman with postpartum psychosis is going to go on to develop bipolar disorder, although many will, as the take home. What are some risk factors for postpartum psychosis? So family history of postpartum psychosis specifically really does increase risk significantly. Again, we know that, a lot of these women have bipolar disorder, and we know that there's a very strong genetic component to bipolar disorder specifically, but we do see a strong influence of family history in terms of thinking about risk. Really, 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 really high risk in subsequent pregnancies. So if a woman has an episode of postpartum psychosis in one pregnancy, they are very, very, very likely without treatment to have a recurrent episode in a subsequent pregnancy. And primiparity does significantly increase the risk of postpartum psychosis, which may be because, women who have had one pregnancy affected by postpartum psychosis they and their family and their providers are going to be much more likely to aggressively prophylax them in subsequent pregnancies, be that as it may. But interestingly, unlike unipolar depression, where we really have very, very clear, kind of well-defined life stressors that we know increase risk for postpartum depression, we know that life stressors, influence the incidence and the course of postpartum depression in unipolar depression pretty significantly. Studies have really consistently found no association between stressful life events and the onset of postpartum psychosis. Stress and postpartum psychosis are not correlated, which I think again really underscores sort of, the really powerful kind of biological nature of this phenomenon, of this illness. Okay, so how do we best screen for bipolar disorder? And we see that misdiagnosis, like we said at the beginning, misdiagnosis is really, really common in both directions. A lot of women with bipolar disorder, especially women with more subtle hypomanic symptoms that, that they may not register as pathological because they don't cause a lot of functional impairment. A lot of those women are missed. And similarly, I think what you see, I think, a lot more in the inpatient end is misdiagnosis in the other direction, women who come in and believe they have bipolar disorder, but may not. But when we miss a diagnosis of bipolar disorder, it's important. Again, right, like in cross-section, a lot of these women are really going to look the same as women with depression. Like the depression looks exactly the same, but the treatment's really different. It's really apples and oranges, which makes it really complicated. And when bipolar disorder is misdiagnosed as major depressive disorder, that can lead to inappropriate treatment. And often we see this sort of as a factor in treatment resistance, like the, kind of a subtle hypomania is missed, and so treatment is inappropriate and patients don't get better. Or sometimes, can get even worse. Use of SSRIs in bipolar disorder is controversial, but we do see in some women, especially women with kind of more frequent episodes, and people in general, this is not specific to women or pregnancy, but when SSRIs are used in bipolar disorder, in some patients, they may be treatment resistant, or they may go on to actually have more frequent mood episodes, which we call cycle acceleration, episodes of both depression and hypomania. Tricyclic antidepressants, which really, we don't use very much anymore, although they are used for kind of other indications. And so we do sometimes see people on them, who turn out to have bipolar disorder. Use of tricyclics are actually demonstrated to induce mania. So these are medications that are clearly contraindicated, in most cases in women with bipolar disorder, or people with bipolar disorder. So misdiagnosis in the postpartum period is likely to be, common as well as it is in other phases of a person's life. again, right, hypomanic symptoms tend to be more subtle. And if they don't really significantly disrupt normal functioning, they might even like not be really noted by the patient, and they might be dismissed by them or their, or their loved ones. Clinicians may not really ask about episodes of elevated mood. That's commonly something that's not asked about. And hypomania after delivery can often perhaps be misconstrued as normal joy related to childbirth. So these are the kind of obstacles to diagnosing more subtle forms of bipolar disorder. Again, sort of another really kind of dramatic number that really sort of, I think, underscores the vulnerability of the postpartum period. So common clinical scenario, like we talked about, women who have bipolar disorder who have been misdiagnosed, or, legitimately their first several episodes have been depressive and they just haven't declared themselves yet. They haven't had a hypomanic episode yet, so we don't know that that's their diagnosis. So women, in that scenario who ultimately do declare themselves to have bipolar disorder, ultimately, they are 18 times more likely to develop hypomanic symptoms in the first 3 months postpartum. So that diagnostic switching, that kind of like episode that kind of like declares the diagnosis as being bipolar disorder as opposed to major depressive disorder, happens 18 times more frequently in the first 3 months postpartum as opposed to any other time in this woman's life. Okay. All right, so now we're gonna move on to treatment. Okay. So, kind of general principles, right? We have to think about risks of medication exposure to the fetus and weigh them against the risks to both mom and baby of untreated maternal illness. And again, really, really important, untreated maternal illness is not benign. I think on the OB end, you guys probably do a better job of counseling patients about this than we may do sometimes from our end. It's an important thing to really, really keep in mind. When we think about management during pregnancy, the factors that we want to think about when we're considering kind of an individualized treatment plan for an individual patient. So severity of maternal illness and frequency of mood episodes. Is this somebody who has, really, really severe illness and episodes that kind of occur pretty frequently, or is this somebody who really, has pretty rare episodes that are not severe? How well have past medication trials worked? What have the effective medications been? Again, we want to sort of really lean towards using medications that have worked in the past for an individual woman whenever possible, and the strength of the maternal support system. So, if this is somebody who really has a really strong support system, if they start to develop subtle symptoms, are the people in their life going to kind of note that and let you know, as opposed to sort of, is this somebody who's going to have to get very, very, very sick before we notice that they're sick? In general, a single medication at a higher dose is preferable to multiple medications. And again, mood stabilizers are not interchangeable. So just because one mood stabilizer works and just because the diagnosis of bipolar disorder doesn't mean we can substitute another mood stabilizer and get the same effects. All right, so moving on now to talking about specific medication. So lithium, right? Lithium is, as we all know, a teratogen. We know it's associated with an increased risk of Epstein's anomaly, which is characterized by congenital displacement of the tricuspid valve towards the apex of the right ventricle. This is something that's been known about lithium for decades. And so there's a lot of kind of understandable caution about using this medication during pregnancy. So in thinking about actual risk though, in the general population, we see a risk of Epstein's anomaly of about 1 in 20,000. So it's really, really rare. With first trimester lithium exposure, the risk of Epstein's anomaly goes up to about 1 in 1 to 2,000. So clearly it increases risk, significantly. But the other really important point here is that while the relative risk is much higher, the absolute risk remains small. So in lithium exposed pregnancies, the risk is still fairly low, like 1 in 1,500. So this is a recent meta-analysis looking at lots of studies looking at lithium. And again, we do see that it is a teratogen with a odds ratio of any congenital anomaly being about 1.81% and a cardiac odds of a cardiac anomaly being similar, with dose-dependent risk, with doses greater than 900 milligrams posing greater risk, which is, these are the doses that we tend to use, and a prevalence of about 4.2% for any malformation and 1.2% for cardiac malformations. So the good news with lithium is that that's really kind of it, right? Like lithium has been studied really, really quite extensively, and Epstein's anomaly seems to be really sort of the major issue that we're contending with, meaning, right, like lithium after the heart is developed, after like we get to 10, tends to be a medication that we can, use fairly safely, without a lot of other considerations. We do see case reports of other issues, but they're really at the level of like case reports, nothing that we see consistently. And generally these effects that we see even sort of at the level of case reports tend to be transient with no long-term sequelae. These effects can be prevented if lithium is discontinued immediately before delivery, but generally this is not a recommended strategy, again, because we know that this is, really high risk if this is a woman who has had a good response to lithium and the postpartum period is so vulnerable. Other considerations with lithium is that it's distributed in total body fluid volume, so levels can really be affected by kind of hydration, so vomiting, changes in sodium intake. Lithium can cause thyroid toxicity, in general, in anyone. And so that's something we want to be particularly careful about during pregnancy. We see increase in lithium excretion in the third trimester, and in general, sort of, closely monitoring lithium dose and levels at delivery are important because of changes in vascular volume. And so, there's sort of this hypothetical thought that perhaps, lithium dose may need to be decreased at delivery for that reason. Although I think, clinically we don't see that all that often, and we just really need to monitor very closely. Other considerations, right, preeclampsia associated with rapidly changing renal function, which can affect lithium levels. And so that's, that's sort of a factor that, needs to be considered very closely in somebody who's on lithium. NSAIDs is really is important. And this is, this is a clinical scenario I've encountered several times. NSAIDs actually really do reduce lithium elimination. And so that doesn't mean we can't ever use those two medications together, especially if it's PRN and especially if the person's lithium level is not super high. But it is something we need to keep in mind, and we need to really monitor these women who are managed with both NSAIDs and lithium much more closely in terms of, checking their levels and monitoring for toxicity. So in general, right, so kind of this is the take home, that in women who really are, who have more severe symptoms, who are clearly lithium responders, are women really who are strong candidates for lithium to be continued during pregnancy. Lithium specifically, I mean, this is true again for all mood stabilizers, but lithium specifically tend to, we tend to see lithium responders, that people who really have kind of a uniquely positive response to lithium, and other mood stabilizers are really not interchangeable. And so, it can be very, very, very important in a lithium responder that they continue their lithium. And then thinking, kind of taking a step back and thinking about the risk benefit ratio in general, we see a number needed to treat of 3 for the prevention of mood episode relapse. So really very, very strong effect on prevention of relapse, versus a number needed to harm of 33 for the risk of any congenital anomalies. So kind of thinking about the risk benefit ratio in that way, especially, in women who really benefit from lithium, would seem to sort of lean in favor of continuing it. Patients with less frequent and less severe episodes may be able to discontinue lithium during pregnancy or during the first trimester. There are people out there in the world who have had 2 lifetime episodes. They're not likely to relapse immediately after their mood stabilizer is discontinued. And again, this is clearly, a risky strategy regardless. But these are people who, historically on looking at the course of their own illness are kind of more likely to be able to get away with a couple weeks off their medication during the first trimester. We do see that rapid discontinuation is associated with higher frequency of and reduced latency to recurrence of symptoms. So then when we are thinking about stopping lithium, we want to do it kind of more gradually, ideally before pregnancy. And we want to monitor pregnancies that are exposed to lithium, which I know all of you do. Okay, fine. So now we're going to move on to valproate, which is valproate is kind of a different animal, and valproate is really like the kind of the worst teratogen that we have in psychiatry. I feel actually pretty strongly that valproate is a medication that, at least for psychiatric indications, really should not be on the menu for women of reproductive age. And commonly, actually, we do see it used in that population, but it's really striking because, well, let's talk about the data. So we see about an 11% risk for major congenital anomalies, including neural tube defects, cardiovascular anomalies, limb defects, hypospadias. About 1 to 2% of exposed infants present with neural tube defects, occurring about 10 to 20 times more frequently in valproate exposed infants than in the general population. So lest you say, like lithium, this looks like a first trimester issue. Like, is this a medication we could use after the first trimester? And the answer is definitely not. We see it is actually, it causes really very, 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 very profound neurodevelopmental effects. It's the only anti-epileptic medication associated with cognitive delay, with language delay, psychomotor delay, and with autism and dyspraxia. We see almost a 3-fold increased risk of neurodevelopmental disorder, a 4-fold risk of pervasive neurodevelopmental disorder, and a 3-fold risk of intellectual disability in babies exposed to valproate during pregnancy. So, there have been various regulatory responses. In Europe, they're kind of stricter about it, especially for psychiatric indications. But again, this is given sort of the high rate of unintended pregnancy in this country, and, the really, very, very significant issues associated with valproate in general. This is not a medication that should be used in a woman who has any potential to be pregnant or get pregnant. Okay, so really quickly, we're going to talk about carbamazepine, which is Tegretol. It's not a medication that we use very frequently. Tegretol also is a teratogen, and with malformation rates of 2.2 to 5.4% in large pregnancy registries. Relative risk of 2, neural tube defect risk of about 0.5 to 1%, does not seem to cause neurodevelopmental, adverse neurodevelopmental outcomes. Again, this is a medication that's used very, very infrequently, but this is a medication that, we would think 2, 3, 4, 5 times before using in pregnancy, but isn't, absolutely out of the question, like valproate is. Oxcarbazepine, or trileptal, is kind of a cleaner cousin of carbamazepine. Does not produce the same toxic metabolite as carbamazepine, and so it may be less harmful in pregnancy. We really just don't have the data yet to know that that's like definitively true. The largest study was in 333 oxcarbazepine exposed pregnancies, and that demonstrated a malformation rate of 3%, which is within the commonly accepted general population rate. So that's reassuring, but it's really not enough data yet for us to really feel confident. So lamotrigine is often our best option, really reassuring safety data compared to other treatments for bipolar disorder. There were some early studies that showed an increased risk of cleft lip or cleft palate, but that's really not been borne out in later data. And no neurocognitive effects. So, adjusted mean IQ at age, looking out to later childhood, age 6, is within the average range in babies exposed to lamotrigine. The important thing to keep in mind with lamotrigine is the dramatic increase in elimination clearance during pregnancy, and this is can be true with many medications that we use during pregnancy, but really is particularly dramatic with lamotrigine and can be very early. So the elimination clearance can increase as early as 5 weeks. We see up to a 330% increase by 32 weeks with a quick return to baseline postpartum, which is probably related to estradiol-induced upregulation of lamotrigine metabolism, which we also see in women who are on lamotrigine, who are on HRT or on OCPs. But there is a lot of inter-individual variability in lamotrigine clearance during pregnancy. So not all women will have this happen. So about 25% of women will not have any significant increase in elimination clearance during pregnancy and will be able to maintain, the same dose during pregnancy. There's really no, like, lamotrigine levels are really, like, they're not relevant to us in psychiatry so much. There's no therapeutic range established for bipolar disorder that, when we see lamotrigine levels, it's really like relevant for the neurologist. We don't really have any like correlation between levels and sort of clinical outcomes in psychiatry. And so, checking levels is something that some people will do, but I don't think it's particularly useful because we're going to treat the patient at the level. And even if we see the level go down, if the patient is stable, we're not necessarily going to change anything. And so I tend to follow people clinically. And if, just with kind of a very, a high threshold for considering an increase in dose during pregnancy if women start to kind of become subtly a little bit worse. Second generation antipsychotics is really a lot of what we see out there. And so this is a large study with a large Medicaid database looking at congenital malformations and cardiac anomalies in women exposed to second generation antipsychotics. And the results here are really pretty reassuring with no difference in either congenital malformations in general or cardiac anomalies specifically, with the exception being risperidone, which is interesting, right? That's like a really interesting exception. There's no sort of specific mechanistic reason that like kind of makes sense that we can use to explain this phenomenon. Relative risk of 1.2% for overall for congenital anomalies and 1.26% for cardiac anomalies as well. This is a result that bears repetition. So I wouldn't necessarily not use risperidone in a woman who has really responded well to it, as a result of these of this data, but it may not be your first choice. We see really a lot of really good reassuring safety data regarding quetiapine, olanzapine, and aripiprazole. And with quetiapine, that's really has the lowest rate of placental passage, and so it can be a good first choice when an antipsychotic is needed. So neuromotor function, so we know that antipsychotics in general can have neuromotor effects on people who take them. And so the question is, do they have neuromotor effects on the fetus and the infant? And the studies show that actually the infants exposed to second generation antipsychotics during pregnancy do demonstrate neuromotor effects early on in infancy, but these effects tend to abate. But they tend to be resolved by 6 months. So no kind of long-term abnormalities that we need to worry about based on the data that we have as yet. And then metabolic complications are kind of a obvious thing to think about. We know that that there is a strong association between second generation antipsychotics and metabolic complications. Interestingly, we also know that women who have illnesses that warrant the prescription of second generation antipsychotics tend to be at higher risk for metabolic issues. And it was an interesting study that actually showed no association between the use of second generation antipsychotics and gestational diabetes when we control for confounders like indication. That being said, obviously you're going to be monitoring for gestational diabetes really carefully regardless. And that, that should be, I think, a factor that should be considered with women on these medications, particularly olanzapine and quetiapine. We see kind of associated with the highest risk of metabolic complications in the general population. Okay, so moving on really quickly to lactation. So in addition to concerns about medication passage into breast milk, so that's often the question, like what, how much of this medication makes it into the breast milk? That's an important question. But the other really, really, I think, perhaps even more important factor is the impact of sleep disruption on maternal illness. So what we see with bipolar disorder in general, again, not just with pregnant women, but in general, sleep is really therapeutic. And sleep regularity is like super, super, super crucial. You take a person with bipolar disorder who is stable and well managed and not having any symptoms, and you sleep deprive them for whatever reason, because they're having a crazy week at work or whatever, for whatever reason, they're more likely to destabilize. That's a known risk factor for destabilization in bipolar disorder. And so kind of think about this, right? So this is like the perfect storm, right? You have this woman with bipolar disorder who is headed into the postpartum period, which we already know because I gave you, lots and lots and lots of data supporting that this is and you probably know from your own clinical experience that this is an incredibly vulnerable time period for this woman. And then on top of that, you take her and you make her wake up with her baby every 2 or 3 hours, for weeks to months. So this is like really a recipe for disaster, and is extremely likely to cause destabilization. So as part of counseling these women, sleep is like a huge, huge, huge piece when I talk to these women. And when women want to, breastfeed during, and women with bipolar disorder want to breastfeed, or even if they don't want to breastfeed, really sort of a hugely important consideration is their sleep be as disrupted as little as possible. Some of you may have had phone calls from me with my patients. I will tend to speak to the women's OB, the inpatient team, and ask them, please, please, please do not wake this woman up for vital signs in the middle of the night, unless if you really need to, sometimes you really need to, but routine vital signs, unless if they're really, really, really important, I would try to avoid in these women. You really want them to sleep regularly in the postpartum period. Number one. Number two, ideally, as much as possible, we really want somebody else managing the nighttime feedings, not realistic for every woman, but to the extent that it's possible, that's something that we really want to try to do. But then when we think specifically about effects of specific medications, interestingly, valproate and carbamazepine are actually really considered compatible with breastfeeding, which is interesting because those are the two medications that we're, least likely to use during pregnancy. Lamotrigine is actually excreted in relatively high levels in breast milk. Infant serum levels tend to be fairly high, but we don't really see any clinically relevant adverse effects consistently described as a result of this. So, higher levels, but not necessarily translating into clinical outcomes. And so, I do have a lot of women I take care of on lamotrigine breastfeed if that's what they want. Obviously, we need to be monitoring the baby as we always do. Relative to olanzapine and quetiapine, risperidone is actually excreted into breast milk in relatively higher levels. It's also something to keep in mind. We have limited data with aripiprazole, but interestingly, unlike basically every other antipsychotic, which increases prolactin, like antipsychotics are notorious for increasing prolactin because of, interesting mechanistic ways that aripiprazole works that are not worth getting into. Aripiprazole actually decreases prolactin. So, in the postpartum period, it could potentially be associated with impaired milk supply. That's something to look out for. The lithium is really an issue because the amount of lithium really excreted into breast milk varies considerably. Infants can be more susceptible to both dehydration and lithium toxicity. Many experts who are managing women on lithium during pregnancy will discourage breastfeeding. Occasionally, a woman who's really very, very reliable and motivated can continue lithium with close infant monitoring, but that's sort of the exception rather than the rule. So I think we are out of time. I am happy to take questions if we have a minute or two for that.
Thank you so much. That gives us, I think, a lot to think about. I'm sort of thrown back to the first part that you talked about in terms of the patients who come to us and say that they have a diagnosis of bipolar disorder, but probably don't truly have bipolar disorder, and whether there's a something that we should, how a approach that you would recommend for that.
Yeah, I mean, that's a great question. And I don't know that that's not screening we're necessarily expecting you to do. I'm just sort of speaking to, I think, kind of what, obviously you're not in a position where you're going to be able to take kind of a lifetime history of, of mood disorder, of mood episodes, and whether they were sustained or not. I'm mentioning it just because I think it is a factor that comes up really, really quite frequently. And just to be aware of the fact that like what is billed as bipolar disorder, in many cases is not bipolar disorder.
Congrats, that was really interesting, and we've interacted for so many years. Thanks for the update.
Thank you.
A quick question on the Edinburgh scale, the screening, which is always the matter of a lot of studies and stuff. We recently saw a study that was proposing to take out question 10, the question on suicide, out of the scale, saying that, it's the test would screen for depression just as well without that question. But then the question came up, that may be actually the most important question on that thing. And while we may not have data, if we can present one suicide for every whatever, 100, 1,000, 1 million screens, I'll take that. Any data or opinion on that particular question?
Yeah, no, that's interesting. I mean, I think, the Edinburgh has not really been validated in women with bipolar disorder. It doesn't mean you shouldn't use it. I agree with you that I think as a screening tool, it's important. And I think the question about suicide is important because it's a screening tool, right? Like you want to sort of like capture 100% of potential bad outcomes, right? Like that's the role of an ideal screening tool. That being said, again, I think, where sometimes often what happens is, we work with a lot of women, and you work with a lot of women who may have a lot of, affective dysregulation and, mood instability and unstable relationships. And we see a lot of sort of transient kind of conditional, perhaps suicidality kind of in that setting. And so often those are women that like our consult team are going to come in and say, like, we're really not worried about this person. Like this is, somebody who's, kind of at chronic risk, but at no more of an acute risk right now than they are at any other point in their life. And, there's going to be a large number of women who are going to look like that. And I don't know that that's necessarily anything that, we can expect you to be screening for. But, that is, I think, often what happens. And, I think something that we can expect can happen and, probably should happen as part of the process, because again, it's a screening tool. So we're going to capture a lot of people that we're not concerned about, but, we probably should be doing that. I think there was a question in the chat. Okay, what are the first steps to take when we see a woman who has stopped all her meds for bipolar disorder when she realizes she's pregnant? That's a great question. That's like such a great question. So yeah, I mean, the right answer is send them to us as quickly as possible. The realistic answer is that's sometimes challenging, unfortunately. I think, in a situation where you have a woman who's, where there's really very, very clear history that they've like really done well with the medications that they've been on. And, it's not like they're on Depakote, because stopping Depakote, if you find out you're pregnant, actually probably is a good decision. But other than that, most of the other medications that we work with, we're not going to reflexively stop when somebody finds out that they're pregnant. And so, I think, restarting them on the medication that was working for them at the dose that was, and getting them to the dose that was effective for them can be a really, really good strategy, or especially, kind of to start that process while they're waiting to get in, to get in to see us. And I think the other really, really important piece here is the counseling piece, right? Because the woman's going to stop their medication because they're terrified, and they're understandably terrified. And a lot of people, have, told them things that have given them good cause to be terrified. And so I think we have to understand that. I think what can be really, really helpful as part of counseling, and what I do with all the women that I work with, is talk about not only the risks of medication, but really the risks of untreated illness. And this can be really quite liberating, right? Because this sort of dynamic is set up with these women where they're kind of told, like, well, choose between your own happiness and hurting your baby, right? And like, that's terrible, and it's not true, and it's not fair. And especially, a woman who might be depressed and have kind of a, disproportionate sense of guilt might be, even more strongly affected by this. But even not in that case, that's a really, difficult thing to hear and is not fair. But when we, I think when we frame it as, you really have to think, there's a really serious risk benefit analysis here. And we're not necessarily protecting your baby if you're unstable, right? Like, if you have untreated illness, that's not necessarily protecting your baby. That actually might be worse for your baby. And that can be a really freeing conversation to have.
I actually had one last question. Are there certain populations that have their first episode postpartum? I guess I'm just wondering if there's like just certain people that are presenting for the first time clinically that weren't able to prior to pregnancy and just haven't declared themselves.
Yeah, I mean, we see that a lot, right? And we see that, kind of bipolar disorder in particular is really kind of a setup for that, because, kind of the age of onset is often when women are, potentially, starting to have babies. And we see that the postpartum period is like a hugely, hugely vulnerable period. So it's very, very common for a first episode to present itself in the postpartum period in the population, like in general. Again, right, like thinking about in bipolar disorder, sort of like we see very often as kind of women who have had, subtle depressive symptoms and haven't declared themselves as having bipolar disorder yet. They may not have chosen to treat those depressive symptoms because they might not have been, significant enough that they, that the woman, decided that they wanted to embark upon treatment. But then we see sort of a, kind of really precipitous onset of mania, hypomania, or really more severe depression in the postpartum period. Is very, very, is very common. And so I think, kind of screening for subtle symptoms is really all we can do. We can't obviously catch the women who have had no symptoms before the postpartum period. That's something we kind of have to manage as it comes. But subtle symptoms are I think pretty common, and and potentially can be caught and tracked.
Thank you.
Okay, thank you, everybody. This is great.
Thanks again. Thanks for being with us. Thanks for everybody for listening. Have a great day. Thanks again.
Thank you.